Actually, for our last discussion, our last course that we did, the liver group, they asked us to put it in mock format, MOC. So eventually, that's the way you're going to get CME credit now, and also recertification credit. So if you collect enough of these, but we have to do the questions exactly right, actually. So we have to have questions, answers, and then a little sentence or two to explain what we're doing. So that's why you see these questions here along the way. So I'm sure you guys are aware of this, actually. New York State law, since October 2013, requires Hep C screening offered to every individual born between 1945 who gets admitted to the inpatient hospital, actually, or who sees their primary care doctor, or who sees their primary care OBGYN. It's not mandatory, it's just the offer is mandatory. So we've been getting some numbers over in IMA. We started really slow. We actually looked at how many, before we intervened, and then there was an educational component. Well, before we intervened, it was virtually zero. And then there was an educational component, and then it got to like 0.1%. Shows you how good educational components are. And then there was the flag, those wonderful yellow flags on Epic. It got to 20%. And then we did the combination, education and yellow flag, and it got to 20.1%. So now actually there's a little competition going on now. Everybody's getting their, starting to see who's doing better than them in terms of, physicians are pretty competitive. So actually with all the other interventions now, we're up to close to 89% actually screening. Baby boomers. We probably should be screening everybody else too, because we'll talk about that actually. And actually this is something that's in all of our package inserts now for DAA drugs when we're treating Hep C, is Hep B reactivation. So you might see this in the hospital. Actually, it's kind of important if somebody's just getting started on treatment. Mostly, just to make it simple, these were 29 cases, mostly from Japan, and mostly because they hadn't been screening effectively for hepatitis B. So part of Hep C treatment, you have to screen for A and B, and vaccinate for A and vaccinate for B if they're not eligible. But the screening for B is S antigen, S antibody, and core. So you have to do all three. So, and basically what happened here in most of these Japanese patients, all they did was screen for S antibody. If it was negative, they gave them a vaccine. They didn't check for S antigen. So basically the hepatocyte is only capable of making one virus efficiently at a time. So if you've got 5 million IUs of hepatitis C, and you've got 500 IUs of hepatitis B, when you kill off the hepatitis C, the hepatitis B has the whole hepatocyte to itself, and it takes off, actually, and can cause a flare, liver failure, et cetera, and that's kind of what happened. So they weren't really looking. So if you've got both B and C on board, you need to put them on a B medication before you give them the Hep C treatment. So you see a big B flare, fulminant B in the hospital. That's one of those things to keep in the back of your head. Could be a flare because of Hep C DAA. Although, frankly, amongst our colleagues, did you guys see any at VCU? I think you said you had one.
One reactivation, and it was one in the community. We didn't check.
Yeah, none in our institute. We've treated over 6,000 patients. We have not heard one actually. So maybe we've gotten them to screen correctly. Anyway, so all right. So here's another thing to think about. So here's the case. Christine, 28-year-old Caucasian woman working for an accounting firm on her way to earning her CPA. She's been using IV heroin for about 14 years. I'm not making this up. She started at the mall in New Jersey when she was 14 with her high school friends. She's been in rehab 3 times, but has had 3 relapses. Comes to her GYN for a late period, afraid she might be pregnant, asks her GYN to test her for everything. Everything to a medical doctor and everything to a GYN are probably different everythings. Anyway, so what should the GYN test for? Hep B, HIV, chlamydia, Hep C, syphilis, or all of the above. Not difficult, yeah, all right? This is a softball to get you warmed up here. This is all of the above. Obviously, Hep B is the law for all pregnant women. HIV is standard in pregnancy, of course, and for PWIDs, people who inject drugs. I learned that. Actually, that's the politically correct. It's actually, you also can't say unsafe sex anymore. You have to say condomless sex. I learned that at an AIDS meeting last week in Washington. Yeah, so it's not unsafe, it's just condomless. And this is people who inject drugs. It takes the abuse out of it. Anyway, chlamydia is standard. Hep C is really not tested actually in pregnant women. Most UINs don't even know about it. And then syphilis, of course. So clearly she should be tested for all of the above. Occasionally I get referrals from GYN where it's not quite the same story, but it's like, it's a one-night stand and she was really drunk and doesn't even know who the guy was, and then it's like has to go to the GYN the next week and says, "Doc, test me for everything because I don't know, where this guy was coming from," and the GYN throws in a Hep C test actually, and then we get a false positive antibody, and I've never seen a real positive antibody. Anyway, so she's she's core. I'm sorry, this is supposed to be negative for DNA. That's a typo. So she's core antibody positive. HIV is negative, chlamydia is positive, and she was treated. Hep C antibody is positive, reflexes to PCR positive. You all know now that there are no antibody tests for Hep C anymore in the institution. The entire institution actually does not do antibody tests for Hep C. They do antibody reflexing to PCR. So it took us about 2 years to get that to happen because the lab draws 2 tubes now when you order a Hep C antibody test. So if the antibody test is positive, they'll reflex it through the PCR, so you don't have to call the patient back in. So it's a one-step process. Syphilis was negative, and the pregnancy test was negative. Okay, so next steps should be all except one. AFP, Hep C quant, Hep C genotype, Hep A IgM, Hep A IgG, abdominal ultrasound, birth control pills. So this also makes me crazy, actually, because everybody checks off the hepatitis panel, which is actually the acute hepatitis panel, and it has Hep A IgM and Hep B core IgM, both of which are useless tests unless it's an obvious, acute hepatitis, because we don't really care about that. But this is the one we care about, actually, and of course the B. And if she's negative, then we need to vaccinate her. Okay, so are you surprised that a young woman, not a baby boomer, would be coming in with hepatitis C? Yeah, I thought the epidemic was over. No, PWIDs are all over the place. Yes, she has a job. No, I'm aware of the new epidemic in young people. Yes, you weren't. Okay. Now the epidemic in under 30 is about the same size as the baby boomer epidemic. Actually, here's the CDC. From May, new Hep C infections nearly tripled in the U.S. over the last 5 years. People kept saying to me in 2015, okay, you're going to retire now? Hep C's cured, right? It's all over. Nothing left to do. Well, guess what? We actually haven't taken more out of the pool than have come into the pool since 2015. So it's huge. This is hepatitis C infection among reproductive aged women and children in the U.S. 2006 to 2014. This is the age 15 to 44. Look at that shape of that curve here. Actually, it's going north at a pretty much exponential rate. And then this actually increased Hep C virus detection in women of childbearing age and vertical transmission in the U.S. and Kentucky. Here, actually, and look at this. Actually, look at Kentucky children. Also, not quite exponential, but huge. Huge. I mean, it's a massive issue. All this is due to the IV opioid use. It's all over the Northeast. It's all out there in the Mid-Atlantic states. Maternal fetal transmission is booming. We actually one of our other new liver hires, I should have brought her along today too, is Tatiana Kushner, who some of you may remember as a resident. Tatiana wants to do women's liver disease, and she's writing a protocol for this. She's done a lot of pregnancy transmission of hepatitis B, maternal fetal, mother to child, MCT, transmission of Hep B work before, and we're going to add Hep C to that now because there's this big push to start treating Hep C in pregnant women, since the Hep C drugs are pretty much all category B, and we would probably only have to treat the last 2 months of pregnancy, months 7 and 8, and we'd have our 8 weeks in, and we'd have the mother cured and the baby pretty much completely protected from Hep C. So we're working with Rhoda Sperling on that, vice chair of OB, actually, and Rhoda has a really fascinating history. Actually, Rhoda was the first. She actually wrote the first paper in the AIDS clinical trials group back in the 90s. Actually, it was a New England Journal paper using AZT to prevent mother-to-child transmission of HIV. So she did the first mother-to-child prevention study of HIV. So here's a woman giving birth in Tennessee, and look at the numbers here. But you can see where the heroin epidemic is here in the Northeast, in these states, actually even some up here in Montana, and some in Alaska and New Mexico. Actually, there it's mostly on the reservation, where it's huge. And here's the counties in Tennessee. I mean, look at this, these numbers, 25 to 78. And of course, Hep C infection during pregnancy is also highly associated with chlamydia, gonorrhea, syphilis, herpes simplex, and Hep B. Because clearly there's probably some condomless sex going on if they're getting pregnant. So here's the second wave of Hep C in the heroin epidemic. And this is actually 2011. We started seeing this. And that's the baby boomers. Oops, sorry. This is so 2005. Here's our famous baby boomers. 2012, you start to see the second peak. By the way, female is blue here, male is yellow. Notice that's actually the vast majority of these new infections are women, and here too, it's like 64% in New York State now of the under 30 group with Hep C are women. Much more likely to become addicted to opioids, to prescription opioids, and then transfer over to IV heroin. And of course, much more likely to get pregnant and give birth to Hep C positive babies than the men are. So we're working with Rhoda to try to get screening done everywhere in all of our OBGYN clinics. Actually, so Tatiana will be going to Rhoda's 2 high-risk OB clinics, and she'll be going to all the GYN clinics trying to make sure all the OBGYN folks are screening for Hep C, not just in the baby boomers, but in everybody as well. So we can try to pick these people up there. And we've also started screening in the ER downstairs. So it's not been very successful yet, but our new chief of the ER is actually a very enthusiastic screener, as is Yvette Calderon down at MSBI. So we're trying to increase our numbers, because the numbers that we've seen published from the ER around the country are absolutely staggering. The first paper came from UAB Birmingham. It was 2 years ago. They just looked at baby boomers in the ER. UAB Birmingham for 6 weeks in the summer, 12.5% Hep C positive. 12.5. They looked in Oakland, it was about 8%. They looked in Seattle, it was about 6%. And then they went to Baltimore and they won the prize at 18%. Actually, it wasn't just baby boomers; it was actually anybody who walked in. 18% of Baltimore, one of the Hopkins ERs. Anyway, so she comes to you. She's genotype 1A, 4 million units, stage 3 fibrosis, stage 3 out of 4, so she's got transition to cirrhosis already. Normal ultrasound, Utox is positive for both opiates and benzos. Says she wants to remain clean, but she can never guarantee it because she knows she's relapsed before. So do you treat her Hep C? Yes, but only after she comes out of rehab again. She's clean and sober for 6 months. If you're a transplant surgeon, that's what you say. No, not till she's clean for a year. Yeah, treat her now. No, she'll never respond, though she'll get reinfected if you treat her. So who wants to treat her? Who wants to wait? Treat her, right? Yeah, why not? Yeah, actually, there's no reason not to treat her now. Actually, I mean, she's probably not sharing needles, not going to needle sharing parties. Actually, she's working for Pete Marwick Mitchell and a big accounting firm downtown. She probably got clean needles. I don't think it's an issue. ASLD says treatment is recommended for all patients with chronic hepatitis C infection without qualification. They do qualify a little bit, basically, if with a life expectancy of more than 1 year from some other disease. So if they've got metastatic lung cancer or metastatic breast cancer or something, but probably don't have to be rushing. These are treatment recommendations for genotype 1B. She's got 1B, sofosbuvir, sofosbuvir. This one we probably wouldn't use anymore because it's 4 drugs. Grazoprevir, elbasvir, which just got approved actually last month. Sofosbuvir we wouldn't use anymore either. Simsof we wouldn't use anymore actually either. So we have plenty of options. Mostly not your choice. It's mostly the choice of the insurance company. So also most studies show that PWIDs will respond quite well. SVR rate is the same. Actually, and even if you go to methadone clinics and you actually check, if you check methadone clinics by doing UTOX, over 50% of the people in methadone clinics are using something else, actually. Are using, benzos or methamphetamines or something that's not methadone, actually. And their SVR rates are actually just as good. So it's almost everybody we treat now, the SVR rate is 90+%. Whether they have HIV, whether they're actively using IV drugs, whether they're on methadone, whether they're older, they're younger, it doesn't really matter. Reinfection rate is very small in the PWIDs, 5 to 7%, compared to about 25% in HIV positive men who have sex with men. So this is our biggest sort of problem in big cities. That's a new epidemic. It's the newest STI among HIV positive men who have condomless sex with men, because Hep C is a sexually transmitted disease in MSMs who are HIV positive because they don't use condoms. So that's an issue. There's always a debate about whether you should be treating those aggressively or waiting until they get over their sex addiction. But most people are treating and hoping we can reduce the population viral load so that we can reduce transmission in that group. Now, you have to be a board-certified transplant hepatologist to do this? Actually, no. Actually, here's a nice study that looked at treatment efficacy by provider type. This is NPs, primary care MDs, specialist MDs overall. Overall, the specialists did worse. Now, I think that's actually selection bias. They sent us the hardest ones, the cirrhotics, et cetera, and the NPs picked the easy ones, the low-hanging fruit here. But at any rate, it's not that difficult, really. It really isn't. I mean, there's a few caveats, basically, because I try to talk to I sent a PowerPoint down to our IMA is very active in treating Hep C, but it's like they should not be treating child B cirrhotics down there, okay? Should not be treating people with HCC down there, or somebody with low platelets, because that means they have varices and they need to be banded, or at least scoped for banding. And they should all get a FibroScan, frankly, because anybody with stage 3 or 4 disease needs to be screened for HCC for life, as far as we know now. All this fibrosis actually gets better and goes away, but we do know that people are at risk for HCC if they've ever had any kind of serious fibrosis. So that's why they need to have a FibroScan. So, obviously we'll do it for them. We got a lot of them. So task shifting for non-specialist providers. We've been doing this here at Sinai forever. These guys didn't come out quite as good. It was 86%. But real-world cohorts of patients at urban FQHCs, you all know what those are? Yeah, no? Federally qualified health centers. Okay, they're scattered around the country. They're actually for people without any insurance, without Medicaid or
settlement and ranking are FQHCs, right?
Yeah. Yes, right, exactly. Exactly. And actually, the number 3, in the top 3 diseases that FQHCs are required to treat and who actually see, because it's the most common, is Hep C. So these are primary care docs who are actually required to be treating Hep C. So we have a bunch of actually outreach programs, ECHO-like programs, to work with FQHCs around the metropolitan area where we do telemedicine basically and work with the individual centers. We also have we're also part of a PCORI grant down at MSBI, which was actually written by Andy Talal, who's in Buffalo, actually to do telemedicine right in the methadone center. So it doesn't really matter where you are when you do telemedicine. So Andy sits in his office in Buffalo and actually sees the patient, on Skype, and they have a discussion, and then he writes the prescription and does everything there. But we're working hard to get a U01 to bring that back closer, so our folks at the hospital in MSBI can actually write the prescription, do the telemedicine. As you probably understand, it's very difficult to get methadone patients to go anywhere else than the methadone clinic. So you really want to try to take the medical care to them rather than, and only 2 of our 12 methadone clinics are actually licensed to practice medicine. So, but you don't have to be if you're doing it from PAC, for instance. Makes sense. So we've also got 6,000 methadone patients in our Sinai system, and the data is so sketchy we have no idea. But in general, most methadone patients, it's about 90% of them are former IV drug users who have Hep C. So we probably think at least 5,000 of those 6,000 have Hep C and need to be treated. So then this is the PowerPoint, actually. All patients need a FibroScan. If you've got an HCC with Child's B or C cirrhosis, you're decompensating, GI bleed, platelets less than 120. They have some overlap problems, ANA, antimitochondrial antibody, HBsAg positive, any other liver diseases, alpha-1 hemochromatosis, very high AST and ALT, CKD stage 4 or worse. Actually, we had a meeting last night, which was actually very controversial about this. We actually had a patient. We had her all actually in the T box, ready to go. She had stage 4 kidney disease, and Tanya Kim, and we were working with Tanya to help control her blood pressure and going back and forth, trying to get her all tuned up. And then she's finally ready. We wrote the prescription, and then they call us like 2 weeks later, and we said, "Oh yeah, the prescription's here. We're ready to go." They go, "Never mind. We transplanted her, last week. So when can you treat her Hep C?" Now, as soon as possible after transplant, because they got a Hep C positive kidney. So that's the good news about the opioid epidemic, actually, is that the supply of Hep C positive kidneys is huge now, and they're all young, healthy, Hep C positive kidneys, as well as young, healthy Hep C positive livers that are being donated because the young folks have been signing their donor cards on their driver's licenses, right? How many of you have signed your donor thing on the license? Oh, good, look at that. Okay. Look at all those fresh young organs out there. But of course, we get twice as many kidneys as we do livers, actually. So frequently, the waiting time for a Hep C positive kidney here now is measured in weeks, whereas a Hep C negative kidney is measured in years, like 7 years is the average wait here at Sinai for Hep C negative kidney. And the mortality rate on dialysis per year, 20%. 20% per year, actually. So that's 140% times 7 years, right? It's like, it means a lot of them are going to be dead in 7 years. So first thing we do now is, is go see renal transplant, see if you're eligible for a transplant. If you're eligible, we're not treating you. Go get a Hep C positive kidney. But then we do have to repeat the genotype of the Hep C because we don't know what what the new genotype might be. Cirrhotic HIV positive patients, and then screening for hepatitis B. The VA has done actually very well in terms of treatment. They have about 5 million patients there, Hep C diagnosed in 3%, about 174,000. They've treated actually about 78,000 of those. They've done actually quite well. It actually makes a lot of financial sense for the government to do this, because Medicare will pay for Hep C treatment without blinking, and the VA also. Because if you think about it for a second, actually, it even doesn't matter how much the cost. I'll show you how much the costs are, but it's incredibly cost effective to treat Hep C. Even if it's $100,000 to treat them, you get your return on investment back in about 4 or 5 years, because the all-cause mortality is 300% higher in patients who have Hep C compared to patients who don't have Hep C. So it's not just liver disease, it's diabetes, it's hypertension, it's renal disease, it's malignant it's myeloma, it's non-Hodgkin's lymphoma, it's all these other things actually that creep up and cause morbidity and mortality. So Hep C patients are really expensive patients. So Medicare pays for it without blinking, because you only go off Medicare feet first, right? And so if you make it to 65, your chances of living to like 80 are now like 90%. And the same thing with veterans, okay? You never become an unveteran, okay, until they fold that flag up, okay, and give it to the widow. So they're stuck with these folks for life. It's very cost effective. They get their money back actually very soon in terms of healthcare costs. I wish our commercial insurers and our managed Medicaids were so, had such long-term, positive thinking.
You're in favor of a single payer?
Well, you got to align incentives. It doesn't have to be single payer. We're actually working a deal here at Sinai with Mount Sinai Health Partners, the business guys here. DC 37 is a union, the Health and Hospitals Corporation union. Basically the employees that work down in the basement, the guys that are sweeping the floors and doing that, and they have not paid for Hep C treatment, actually, period. No treatment whatsoever, because they said they couldn't afford it. They have 300,000 members, and they think they have 200 patients with Hep C. Well, what the prevalence in IMA is 8.3%. So I think the prevalence in this group of lower level hospital workers is probably going to be about 8%. So that's going to be about 24,000 out of the 300,000. So we actually are making a deal with them to treat all their Hep C if we can do it in an Article 28 facility. So we get the discount for the drugs from the 340B program. That's a little complicated, but we get a rebate from the government actually. So if we can, that basically we can share our savings with the union here and do it that way. So we'll contract with the union to take all their Hep C patients basically for a certain price, and they'll get it cheaper and we'll make money in the process. And we've got 7 sites around the city that we own that are Article 28s. So there's some room for entrepreneurial spirit, I think, in here as well. So the real world effectiveness of the VA has done really well overall in the mid-90s. Genotype 3 has been our toughest one to treat up until now. We now have better drugs. We also have guidelines on using the FibroScan for fibrosis measurement. It's a marvelous machine. Actually, we don't have to go through this. Basically, it's called vibration controlled. Do you all know what it is? No? Okay. So vibration controlled transient elastography. It has a probe that you hold in your hand with a smaller probe that sticks out that actually taps on your liver. It sends a sound wave through a shear wave through your liver, and it measures the speed with which it traverses the liver and comes back. So if the liver is really hard, it comes back fast. If it's really soft, it comes back slow, right? It's originally invented by the French, believe it or not, to see if the cheese was ripe. You know those big wheels of cheese? You've seen those on TV? It's like the guys who could just walk into the room and like sniff and tell if they were ripe are all died off. There's no that talent anymore. And you can't put a knife in it. You know, well, I guess you could do a cheese biopsy, maybe, but can't really put a knife in it. You risk ruining the cheese and getting it moldy in the center. So they invented this machine to tap on the cheese to see if it was ripe, actually, and then they decided to tap on somebody's liver to see if it was ripe. So, and then obviously you want your liver to be like a nice ripe brie, okay, rather than a really hard Jarlsberg. So it tells us actually exactly how how stiff your liver is, and it gives us a very good sign of fibrosis. Amon is an expert in this machine because we also actually now have a CAP probe which actually can measure fat at the same time. So we can measure fibrosis and fat with the same reading. It's just a different algorithm. So we're trying to get the FDA to substitute this for liver biopsies in our fatty liver studies. So far, not been lucky. Yes? It's about the same as liver biopsy. The AUROC is just about the same, about 85% accurate. Those other ones, the FibroTest, the fibrometer, et cetera, are closer to like 50 or 60%. So this is pretty much as good as a liver biopsy.
It only takes 2 minutes.
Right. And we have them in the clinic, and we know right away. It's like, and well, there's 2 other really nice uses for it other than the original one. One, when you cure them, their Hep C, it gets better, and the patients are like, wow, look at that. It's like I no longer have cirrhosis. And I said, well, but we're still going to treat you, like cirrhosis because we got to screen you, for HCC. But cirrhosis starts at 12.5, and we start at like 25 or something. Well, then the next 6 months later, it's 12, and then it's 8, and then it's 7. It's remarkable how much better it gets. If you do biopsies to follow it up, it's probably not as exact as the biopsy in terms of the fibrosis regression, but that's okay, because we're still going to think about it. And then the other reason is when it gets above 44, because it goes from 0 to 75. So when it gets to be 44, okay, that's the oh shit number, okay, because that means that patients got a chance of decompensating their cirrhosis of about 85% in the next 2 years. Oh, I did say oh shit on the recording. That's like, sorry, strike that. So it's about 12 point, and then 9.5 is stage 3, and that's why we say that's where we have to start screening for HCC assiduously, even after we cure them. Okay, so approved direct-acting antivirals. I don't think you have to remember all these, but just give you some the class effects here. Okay, anything that ends with a provir is a protease. Okay, that's easy. Anything that ends with an asvir is an NS5A. And anything that ends with a bouvir is a nuke or a non-nuke. So you can generally understand which classes of drugs they are. So these were not supposed to be approved when we first made this list, but these 3 just got approved actually this summer. So voxeloprevir approved in July, and these other 2 approved in August. These 2 are coming. Now, these are all the investigational studies. Okay, we're going to go over each one by one. No, we're not. Basically, they work. The numbers are unbelievable. It's like 99% for everything. It's really incredible. So this is the voxeloprevir announcement. It's a protease, but it's actually Vosevi is the fixed dose combination of sofosbuvir, velpatasvir, which is the NS5A, and voxeloprevir, which is protease inhibitor. So it's triple therapy. It's really only approved for use in people who have failed prior NS5A based therapy. Although, actually, this is an interesting point. In Europe, this is voxeloprevir here. In Europe, and so it's only for failures in the U.S., but when they examined the numbers in Europe, the EMEA, the European equivalent of the FDA, took out the American patients, because this is actually 12 weeks of treatment. They took out the American patients actually, and they looked at only European patients. Actually, it's now in Europe, you can use it for 8 weeks for naive patients as well that have never been treated, because the SVR rate was like 99%. But when they added the American patients back in, actually the SVR rate dropped to like 89 or 90. So in Europe, it's approved for naives for 8 weeks, but in the US, it's only for previously treated patients and for 12 weeks. And it's not, here's the other couple rules to remember. No protease inhibitors not to be used in patients with Child's B or C cirrhosis, because they accumulate in the liver, they're all metabolized in the liver, and they accumulate and cause liver toxicity. That's the bad news. The good news is you can use them in patients with renal disease, actually, and there's no renal limitations because they all metabolize in the liver. So they don't go through the kidneys, so you don't have to worry about that. So here's soft Velvox. The numbers are shocking. 93% with cirrhosis, 99 without. Soft Velvox for 8 versus soft Vel. This is Epclusa. It's all 95, 98, 96, 99. It's insane now from where we were standing. Virtually no side effects. Occasionally patients complain of a little headache. And then Voxeloprevir has a little bit of diarrhea. 10 or 12% of people might have a little touch of diarrhea. Honestly, we did the trials here. I didn't have anybody complain about it, but you know, it's in the package insert. So if you see anybody on it, it's probably something you shouldn't be doing at home. You know, it's treating failures. Those are the ones you probably should send down to the liver group. On August 3rd, Mavorette got approved, which is a fixed dose combination of Lenacapavir and Pabrentasvir, so formerly known as GP, because they're easy. So this is the protease, and this is the NS5A. They're both actually really potent, pan-genotypic, so you don't have to worry about the genotype. 1, 2, 3, 4, and 5, and 6. This is the testing for Hep B, and it's a fixed dose. It's actually 3 pills once a day, but it comes in a very neat little package, so it's idiot-proof. Basically, there's 3 pills in each little package, so you can't forget whether you took it or not, basically, which happens, I think, all the time for people who take a lot of medications. It's 8 weeks without cirrhosis, 12 weeks with cirrhosis that are Child's A. Remember, it has a protease, so no Child's B. And here, and then it's 16 weeks in patients who have had an NS5A. Don't do that. We're not going to do that. We're just going to use Vosevi, the previous drug, and people have failed because the numbers are so much higher. These numbers, well, I'll show you the numbers. They're not so good. Remember, no Child's B or C. Here, so here's the clinical trials. 91, 99, I'm sorry, 99, 99, 99, and 99. It's unbelievable. It's unbelievable. And there's 12 versus 16 weeks in the previous failures. Here, it's only 91% here, but it's only 22 patients. This is renal impairment. This is where this really shines. It was 98%. In renal impairment, because you actually get higher levels, in the body. This is what's coming next summer, actually, coming to your theaters next summer, the Merck triple. This is Uprofosbuvir. Now, what kind of a drug is that? Is that a NS5A, a nuke, or a protease? Uprofosbuvir. It's a nuke. It's a nuke, right? And what is the Grazoprevir? Protease. Right, and the Rusasphere, NS5A. Okay, this is the triple, the Merck triple, and actually genotype 3, which has been our biggest problem to date, 95, 97, 96. Big numbers, but it's like huge. It's huge. And this is retreatment with these 3, 100 here, 100. There's only a couple of patients, small numbers. This is prior DAA failures, 16 versus 24, 98, and 100 for failures for previous treatment. So I mean, basically, there's not any reason to worry anymore. You know, you can. It's well, I tell the patients it's a really good time to have hepatitis C, to get it treated, because even if you're in the 2% who fail, we got Plan B. Okay, we got Plan B. We can fix this. It's not a problem. Now, so here's the big thing that we try to teach our non-hepatology folks. If we cure them, their risk of HCC, if we don't cure them, is huge. If we do cure them, it's not zero. Okay, it's still there. So we've got to keep screening. So, sorry, we had a question?
Yeah, what are some of the major side effects of the medication?
There's no major side effects. Basically, the only problem we've ever had is LFT elevations in people who have Child's B cirrhosis, who shouldn't have got it in the first place. Most of our patients will say they might feel a little fatigue or headache the first week. We tell them to drink a little more water and it goes away. So honestly, I think out of the 5,000 or 6,000 patients we've treated, we've had 1 or 2 maybe have a rash or something where we weren't sure whether it was related to the drugs or not. So we just tell them stop and we give them something else. There's no, you know, that's what there's almost no, virtually nothing, actually, virtually nothing. Unless you're using ribavirin, of course, with it, which is rare nowadays. And then you have to check for anemia. So, but the big thing to worry about is proteases in Child's B that you don't recognize, which is why those folks should be treated in the liver clinic, not in the HIV clinic or the internal medicine clinic. Okay, and then long-term outcomes, exposure-adjusted de novo HCC incidence rates. So decompensated cirrhosis, actually, incidence per 100 person years here is actually huge compared to compensated cirrhosis. And we see them also, unfortunately, in patients who don't even have cirrhosis. So we kind of stay on top of our ultrasound and our alpha-fetoprotein screening for HCC. Treating Hep C also does seem to actually stop the progression of renal disease. So we've had a couple of people who were hovering right before dialysis that we've seemed to have kept off dialysis. If you cure their Hep C, obviously with one of those compounds that are excreted by the kidneys, by the liver, you seem to stop the progression or slow it down anyway of kidney disease. And in terms of the liver transplant waiting list here, this is in the protease inhibitor area. That's telaprevir, boceprevir. Those are gone now. In the DAA era, actually. And then HCCs have gone way up. We almost never transplant the patient anymore. It doesn't have an HCC. It's because they get the points. And the numbers here in New York are so terrible for the MELD scores. Now, this is what caused a little buzz in the markets when Mavorite got approved, because you could pretty much use it for almost everybody. And the price per month came down to $13,000. Actually, Zepatier had actually managed to get about 50% of the market share in the U.S. by negotiating with Medicaid managed care plans to bring the price down this low. And then actually AbbVie is really undercutting them significantly. So we'll see what happens. It doesn't really matter to me which drug we use, as long as we're not doing the wrong thing for the patient. I wouldn't want to use this one for a NS5A failure or for a patient with Child's B cirrhosis. But other than that, I couldn't care less. They all work the same. They're all close to 99. Actually, in our hands, our first 5,000 patients, we only had 47 failures. In the real world, this is all comers, including the clinic. It's not just the upper middle class folks. So Hep C is very curable now. There's many new combinations marketed. There's lots of opportunities there. And even if you fail, there's Plan B, which it's almost 100% for Plan B. Costs are coming down dramatically, but the risk of HCC, this is what keeps me up at night. Okay, that we're going to miss somebody who needs to be screened for HCC, or they're going to think they're cured and just go away and not come back. And then we'll lose them until they come back with the football sticking out of their abdomen. And then it's like a little late to help them. Because our HCC cure rates now are If they're less than 3 centimeters, they're approaching 100% now as well. So we cure their Hep C, we cure their HCC, their child's A cirrhosis is getting better all the time. They're on the transplant list because they got the HCC points, but most of them refuse a transplant. They don't need it, frankly. Even a nice, new, fresh opioid user liver, they refuse. Yeah. Question?
How do you treat dual diagnosis? Or like dual infection?
With what? HIV? The same.
HBV.
Well, HBV, you put them on tenofovir or TAF before you treat them, or entecavir, depending on their creatinine. Doesn't much matter, but treat them before with HBV and HCV. And then with HIV, Hep C, the numbers, the SVR rates are the same as with mono-infection. You just have to check for drug interactions. So anything that has a protease in it, you pretty much can't use efavirenz, atazanavir, or HIV protease inhibitors. The other drug interactions, which are virtually universal amongst all of these, like the usual suspects are carbamazepine, oxcarbazepine, dilantin, rifampin, the usual suspects for drug interactions, in the P450 system. But EPIC will show you drug interactions, basically in the HIV patients. And almost all of our HIV patients are off proteases and off efavirenz now anyway. They're all on integrase inhibitors, which is what they should be on, frankly. So it's not really much of a worry anymore. Despite that fact, actually, a lot of our HIV providers around the country are still afraid to treat it, and it's still a big issue actually in a lot of HIV clinics, even some of ours actually that are not quite up to speed in treating all of it that they should. And the biggest issue now we have is like getting all of those undiagnosed people, or the ones that are diagnosed but sitting on the fence, getting them in and getting them treated, and getting them cured, so we don't have to worry about HCC or the long-term effects. Because if we are, whether we're a single payer, Andy, or we're the insurance company, which is kind of one way we may be going, if we're the insurance company, actually, which we are for Health First, frankly, then we should take the long view and treat everybody. We are for Health First, but we're taking about $24 million a year beating, actually being what they call subject to adverse selection in the insurance industry. Because we do this well, the patients with Hep C seek us out, actually. And then if they go to the clinic after they're cured, and the Fidelis guy gives them a toaster, then they switch over to Fidelis, and then we just lost all that money. And the Fidelis guys get the benefits. So I think we probably still need a little work on our healthcare system in terms of